Hello, everyone. This is Siddharth Dambar from Chicago Arthritis and Regenerative Medicine. Welcome to our webinar today on regenerative medicine treatments for knee pain and injuries. Before we start, if you could please indicate in the chat if you can see our webinar here, as well as if you can hear me clearly. Okay, wonderful. Fantastic. Great. Thank you, everyone. So we'll go ahead and get started today. So my name is Siddharth Dambar. I'm a physician here at Chicago Arthritis and Regenerative Medicine. I'm going to speak for about 30 minutes. And as I'm speaking, please send me your questions. And intermittently from time to time, I will go ahead and answer questions as well. And I'll make sure there's plenty of time at the end to continue to answer questions. So what can you expect from today's webinar? You'll learn about the best available non-surgical regenerative medicine treatments available for your knee issues, whether you have arthritis, tendinitis, or an injury, what is currently capable and possible in the field of regenerative medicine, and the things you need that your physician should know to figure out whether they're an expert in regenerative medicine, which is very key. Okay, so the big question is, what would you do if your knee pain was controlled? How would your life improve? What exercises would you restart? And what activities with family and friends would you participate in? So who am I? My name is Siddharth Dambar. Again, physician here at Chicago Arthritis and Regenerative Medicine, specialist in rheumatology, specialist also in image-guided musculoskeletal injections. I've been in practice since 2008 and part of the regenerative, participating in regenerative medicine since 2008 and within the Regenix network since 2012. Regenix is the largest affiliation of physicians in the world that are focused on utilizing regenerative medicine treatments as well. So there are problems with traditional care. To begin with, traditional care for knee pain is typically utilizing pain medications, icing an area that's been injured, and just resting. The problem with this is that it masks the pain. It doesn't really attempt to fix the problem, and you're essentially waiting for eventual surgery. The problem with this model of care is that it doesn't work very well. And in addition, it's not how we treat anything else in medicine. For example, if you have diabetes, we don't wait for you to have your first heart attack or stroke before you start treating your diabetes. You start making dietary and medication changes as needed right off the bat so that you don't get those kind of problems. Other problems with traditional care, the pain medications that are utilized typically are anti-inflammatory medications, ibuprofen, Advil, Aleve. They have side effects in terms of kidney, stomach, liver, heart, and bleeding issues if you're using them chronically long-term. Opioids have their own kind of side effects, as we all know about nowadays, in terms of tolerance and addiction, really significant issues that we need to get away from. The traditional injections that are utilized for pain include steroid injections, which on an occasional basis are low risk, but if you're getting them too often, can lead to damaged tissue, infections, diabetes, and osteoporosis. In addition, a lot of the pain management procedures that are utilized, including nerve blocks and radiofrequency ablation, can give pain relief, but they do also damage the nerve, which can then lead to muscle weakness, which is then counterproductive for actually getting better. Surgery, there is a role for surgery in things that are more severe or advanced. The issues are that surgery does have a higher risk of bleeding, infection, tissue damage, and aesthetic risk, as well as cardiac risk. Many routine surgeries are proven not to be as effective as originally thought. That includes knee arthroscopy for people that have knee arthritis. That's no longer in vogue for like the last 15 to 20 years. Essentially, knee arthroscopy, if you already have arthritis, can actually accelerate the arthritic process, creating more instability, and it's not recommended if you already have arthritis. Surgical repair of ACL and MCL tears are obviously helpful from a functional standpoint, but do not actually prevent the progression to knee arthritis. And knee meniscus surgeries, which makes sense in theory, usually they're actually cutting out tissue, which leads to more stress on the knee. They're not actually repairing the meniscus tear. So in searching for better options, we need to have treatments that avoid these side effects and are low risk in nature. They should actually improve the actual cause of your problem, and they should give the chance of better longer term improvement and possibly even prevent other issues longer term as well. So imagine reducing your pain and getting back to the activities you care about without surgery or pain medications. So regenerative medicine is the field of medicine where you're using your own body cells to treat arthritis, tendinitis, injuries, and back pain. If you think about the normal healing process, let's say you have a cut on your finger. You have an influx of platelets into that area. The platelets release certain growth factors, which then stimulate your local stem cells and bring in other cells. That leads to inflammation, which then leads to a progressive healing and cellular repair process. That works very well in tissues that have good blood supply. Unfortunately, for tissues that have poor blood supply, that doesn't work. So that would include tendon, cartilage, ligaments, disc, labrum, and meniscuses. So regenerative medicine is a process of taking those same cells that are involved in your normal healing process and coordinate that normal healing process, and then injecting them under high-level image guidance into that damaged tissue to get that normal healing cascade to work. So why regenerative medicine? Number one, you're really treating the source of the problem. And the source of the problem is that you have tissue that's been damaged and you have tissue that is not healing appropriately on its own. So you're now putting those same cells into that tissue. In addition, I'll explain in a little bit, but you can also treat instability and chronic inflammation, all things that are involved in the actual source and etiology of the problem. These treatments are, by the nature of the fact that they're needle-based injections, and they're not big open surgeries. They're safer than surgery. They're effective for most musculoskeletal conditions. And for those of us that are involved in this, a lot of us feel that eventually 80% of traditional orthopedic surgery will eventually be managed by regenerative medicine. In the same way that at one point, a lot of what was treated by open heart surgery, now 95% of that is done via by cardiologists who are just using needle-based procedures. So how does regenerative medicine work? Really, essentially, we're optimizing the tissue that's been damaged. So when you look at tissue that's been damaged, you have cells that are no longer functioning well. They're no longer creating the right proteins or enzymes that give you a healthy joint. They don't repair well on their own as well. So by injecting the right cells into that same area, you're now getting those damaged cells to start working better. What we know is that the mesenchymal stem cells in a joint that's been chronically arthritic or damaged, if you re-inject your own stem cells or platelets into that area, those cells start functioning better, which is what creates a healthier joint. In addition, we know that in cells that have actually been damaged, you can actually get even those cells to start working and functioning better. The other great thing about regenerative medicine is that when you think about what really drives the chronic degenerative process, it's instability, meaning you've likely had a mild soft tissue injury at some point, and then over years to decades, you then get progressive stress on the joint that leads to that kind of arthritic process. And so we can actually treat those soft tissue issues that have been chronically injured to make them stronger, to give you better structural support, and to give you better function as well as pain relief long-term as well. Other ways that regenerative medicine works, we can actually reduce chronic inflammation that you can see in joint and tendon injuries. I actually have a series of RA patients where we've actually done bone marrow concentrate injections into a joint, one or two joints that may be chronically inflamed or arthritic, and it's made a significant difference in terms of chronic inflammation. In addition, if you have a pinched nerve or an injured nerve, you can actually reduce some of the stress on the nerve with some of the techniques that we use with regenerative medicine. In addition, you can also improve stability in the spine, which can actually take pressure off a nerve, which can then actually reduce pain that you may have in a leg as well. So some basics of regenerative medicine. Number one, is this legal? And really the simple answer is yes. There are, however, very strict guidelines that need to be followed by your physician. To begin with, you need to be using your own cells, not somebody else's living cells. These cells cannot be significantly altered or adjusted. They need to be re-injected the same day, and they need to be injected into orthopedic tissue. If you're interested in treatment for other organs, this is not my field of expertise, and that's actually not currently allowed by the FDA anyway. But for treating things like knee arthritis, injuries, back pain, these are well within the guidelines for what the FDA requires us to do if you want to do this legally. Second question I hear frequently is, if I'm older, shouldn't I use someone else's cells? And the simple answer is no. The vast majority of orthopedic conditions, there's very good evidence that using your own live cells is effective. In addition, there are much more risks if you use somebody else's cells. There's a condition called graft versus host disease where your body will recognize somebody else's cells, and if you inject those cells into them, it'll recognize it as a foreign entity and will actually attack it. So it'll actually cause more problems if you inject somebody else's cells. And also keep in mind that really from a legal standpoint in the United States, you're only allowed to use your own living cells. Also, is there an age limit? Simple answer is no. For most areas, including the knees, there is no limit based on age. In fact, for knees specifically, we find that age is not a variable that leads to worse results or better results. Regardless of your age, you can still be a candidate. The one area where age can be an impact on outcomes include hip arthritis. So that is the one exception there. What sort of doctor does these treatments? It should be a physician focused on musculoskeletal conditions. With medicine in most things, the more of an expert you are, the more finely focused you are, the better you generally are at what you're doing. If your physician is doing some joint treatments, but then doing some Botox on the side and doing some other things like that, they're probably not the right person to be doing this. They're not really focused on musculoskeletal conditions. You should also be a physician that's focused on non-surgical treatments for orthopedic conditions. Orthopedic surgeons are specialized in surgery. They're good at that. These kind of treatments would generally require additional skills when it comes to ultrasound and X-ray guidance, are not skills that orthopedic surgeons are generally taught in training. So you really should have that expertise, and I'll show some examples of that. And I'll go over what really makes a proper regenerative medicine expert. So can these treatments help if I've already had surgery? For the most part, yes, unless you've already had the joint replaced, in which case, if you've already had metal or plastic put into the joint, we obviously can't actually treat that. General rules that I recommend to patients for orthopedic surgeries is, as much as possible, try to keep your own anatomy, avoid surgeries that are strictly cutting out tissue rather than repairing things. And if you've been recommended surgery, always ask if maybe a regenerative medicine treatment would be an option to see if you can avoid surgery as well. So we'll talk about the kind of key core concepts in regenerative medicine, including stability, orthobiologics, and interventional orthopedics. I'll show some pictures as well to help explain some of that. So there's this concept in architecture called tensegrity. It's this idea that if you take a functional unit, if you take the individual units around it, they may be weak on their own, but if you put them in close approximation to one another and put that under compression, the overall whole is much stronger than the individual units. So in biology, that's called biotensegrity. And prolotherapy is this idea that you can strengthen the overall structure or joint by treating all the other supportive tissues around it. So what that means is if you have something like knee arthritis, your treatment should not be only treating the knee joint. You should also be treating what's driving the knee arthritis. And that includes ligaments that have been chronically injured, tendons that have been chronically injured, a meniscus that may be chronically injured, sometimes peripheral nerves in that area, and in some cases, even treating the bone. And by treating all of those structures, you get a better result because you're strengthening the overall unit by treating each one of the individual parts of it rather than only injecting into the joint. So treating that layers and layers of that tissue is important, and the depth of that tissue is important. And understand that this is a slow progressive improvement process. It doesn't improve within the first few days. It can take several months to really get that kind of result. We have evidence that when it comes to things like PRP and using your own bone marrow, that improvement can take up to 6 months, even up to a year. What that does is give a longer lasting result and a better result than the traditional treatments that have been done. So as an example, when it comes to knee stability, improving stability leads to better improvement in pain and function. And as I mentioned, you want to treat all those layers of pathology. So as an example, if you have arthritis underneath your kneecap, that's called patellofemoral arthritis, you want to treat not only the joint, meaning injecting your own cells into the joint, you then want to make sure you treat all the ligaments around that joint that are actually leading to instability and putting pressure on the joint. And then you also want to treat sometimes even the bone that may be chronically inflamed as well. Another example would be if you have a meniscus tear. So the key is to treat not only the meniscus, but to also treat the ligaments around the knee, as well as the other soft tissue structures that lead to that meniscus tear also. If you treat all of that, you'll get a better result. So good question to ask is, can tendon or ligament injuries be treated as well? So this is an example of treating a knee ACL injury. So the short answer is, if you have a tendon or ligament injury, if you have a partial thickness tear, that can definitely be treated. If you have a full thickness tear, sometimes that can be treated. So this is an example where someone who was diagnosed with a full thickness tear had a really great result. This was a young man who had an ACL tear while playing recreational volleyball. He was treated with his own bone marrow, concentrated stem cells. A couple months later, within 3 months, not only was his pain dramatically improved, he was back to dynamic activity, and he actually also had some very dramatic improvement in his actual imaging findings, which I'll show you. So over here, what you can see is, just putting some arrows here. That first arrow, this is the kneecap. That is the thigh bone. That's the shin bone underneath. This is the needle that's going into the knee. And this structure that's lighting up here is the ACL. And I'll show what that looks like on MRI, but important to understand that in order to inject a structure like that deep in the knee, you really need to do that under high-level X-ray evidence or X-ray guidance. You really can't do it any other way. So he's got a really great imaging result here, not only clinical result, meaning feeling better, but a great imaging result. So the image on the left is his pre-treatment MRI, meaning after he was originally injured. So where the arrow is there, shows where that tear is. It's a very hazy, disorganized looking structure, one that doesn't look very intact. And that was described by his radiologist as a full thickness tear. This is his post-treatment MRI 3 months later. And now you have a structure that is much more linear and compact. And that is a great result, because not only has he had a great clinical result, meaning back to normal activities, exercise, and pain relief, but he's also had a great imaging result, giving him a much better chance of preventing him from developing arthritis long-term. The interesting thing is that ACL surgery is what would have normally been recommended in his case. We were able to treat this without surgery in his case, avoiding the 1-year-long rehab process for him as well. And the other thing about something like ACL surgery is that it works well in a lot of people, but it doesn't actually prevent arthritis from developing long-term. And in this guy's case, because we've improved his stability and improved really his ACL to a normal ACL, our 7-year-old woman who had chronic knee pain and arthritis. I'll show some pictures later on of this, but she had pain along the medial or inner part of her knee. In her case, she ended up having bone marrow-derived stem cells and PRP injected into her medial joint, ligaments in the bone. And she's 5 years out, and she's doing really great with 90% pain relief. So orthobiologics. Orthobiologics are the biologic cells and tissues that we inject into damaged orthopedic tissue. Again, that uses that normal healing cascade, as I mentioned before. When you have a small cut in your finger, platelets come in, stimulate your stem cells, bring in other growth factors, and that's what heals your normal process. That's using your own cells. You don't need to use someone else's cells, not only because it's not legally allowed by the FDA, but because the vast majority of data, almost pretty much all the data, when it comes to orthopedic use with these kind of treatments, is using your own cells. And then the last component of that is there are dramatically more risks when you're using somebody else's cells. And so you want to be careful about that. So platelets or platelet-rich plasma is really the kind of first-line orthobiologic treatment. After you have an injury, platelets come into the area to help recruit and repair the actual injury. That uses focal inflammation to help repair that tissue. The growth factors from the platelets help to stimulate your own local mesenchymal stem cells. That's really how it works. So there's a couple different types of platelet preparations that we use. The picture on the right, you'll see a bloody or very dark colored, red colored platelet-rich plasma. That's how platelet-rich plasma is typically made by the vast majority of places that do this. The problem with that is, number one, it's much more inflammatory, which can damage joints and tendons, and it's not what I would recommend. On the other hand, the platelet-rich plasma on the left is a type of platelet-rich plasma where you've taken out all the red blood cells and all you're left with is a high concentration of your own platelets and some plasma. That's a preferred way to do this. The vast majority of places that do these treatments are not using that because they don't have the overall process to do that. So platelet-rich plasma is prepared by a blood draw, centrifuge, concentrating that into a high concentration of your own cells. A high concentration of platelets is what's good for your joints and tendons. A lower dose of platelets is what's generally good for ligaments. We also make another type of platelet preparation called platelet lysate. That's a process where you take your platelets, crack them open, and just take the growth factors. Very good for nerves, and it's less inflammatory as well if you're more prone to inflammation. So this is a case study of a 45-year-old man. He's a cyclist. He presented with left knee pain. He has patellar tendinitis. He was referred by his sports medicine doctor because he was still having pain despite physical therapy. The picture on the right is an ultrasound image of his patellar tendon. This white structure here is the kneecap. This is a patellar tendon, and you'll see some little osteophytes or bony calcifications right over the kneecap. That's where the tendinitis is. So in his case, he had platelet-rich plasma. He had 2 treatments. He required 2 treatments, and he did great. Essentially, after 2 treatments over the course of about 6 months, he was able to get back to his full activity level, and he's done great. The picture on the right, again, this is the kneecap, patellar tendon, that's the needle, and essentially we're injecting cells right where there's a lot of tendinitis there. So 3 years later, he actually presented again, but now his other leg, he'd had some issues in the back of his knee. He had a hamstring tendinitis. Again, we utilized platelet-rich plasma again. And in his case, once again, he did really well and is back to his full activity. So stem cells is the other big type of orthobiologic that we use. It's the main cell that drives tissue repair after an injury. Again, always use your own cells. Don't use anyone else's. At this point, there's just not enough safety data, and the vast majority of data when it comes to treating orthopedic or musculoskeletal conditions is based on using your own bone marrow stem cells. Fat stem cells are another way to do this. This is not legal in the US, however. The chemical that you utilize to free up the stem cells from fat is not considered legal to be used in humans in the US. It is used in a few other countries. There's not as much data for adipose or fat stem cells compared to bone marrow, but there is still some evidence to show that it can help. Understand that you can actually use fat for structural support without using that chemical. That's not allowed. And so we will utilize that in some conditions to actually help treat their structural issues also. The other ones to be aware of, there's amniotic or umbilical cord cells. That used to be advertised a lot until this year. And the reason why it's not being advertised quite as heavily is because the FDA is starting to clamp down on clinics that are claiming that that's a stem cell treatment, namely because there are no live cells in that. And that is the reason why that is the way that you make these kind of products, amniotic or umbilical cord cells, is that after birth, they take the tissue, the amniotic or umbilical cord cells, they take it back to a lab, they then process that, which means that they then pulverize it, gamma radiate it, and basically create it into a powdered form. It's put into a glass vial and then shipped to a doctor's office where it can sit there for 2 years. When it needs to be used, they then put water back into it to rehydrate it, and then they re-inject it. So there's no live cells in that. Multiple organizations have looked at that. Third-party organizations have looked at that, 3 different ones. There's no significant live cells. It can help as a augment to some of the treatments that we do, but it's not a stem cell treatment. IV stem cells, you don't hear too much about that nowadays in this country. There's no proven benefit for orthopedic. Beneficial when it comes to treating your joint, tendon, or back issues. Stem cell treatment outcomes. I always recommend to patients, the things that we can reliably give results on are improvement in pain and function, even in advanced cases, even advanced knee cases. And the reason why is because you can improve stability by treating those soft tissue structures to make a more stable joint. You can improve inflammation long-term. You can also get cells that have been chronically damaged to start functioning better, working closer to normal. And as the overall unit gets better, let's say the knee gets better, if that allows you to exercise more, helps in terms of strengthening, helps in terms of ideal body weight, and generally helps you kind of maintain the lifestyle that keeps that joint healthy long-term as well. So can we improve X-ray or MRI images? If you have advanced arthritis, no, that's unlikely. We're not going to get an X-ray to look different. If you've seen commercials where they show an X-ray looking different, that's really not realistic if you have more advanced arthritis. And yet that person can still have dramatic improvement in pain and function. If you have a tendon tear, as long as that tear is less than 2 centimeters, that can be repaired. If you have a ligament tear, I showed an example of that before, of the ACL tear, where that can be repaired. If you have swelling in a joint, in an arthritic joint, that can also be improved. And if you have what's called avascular necrosis, that can also be improved as well. So this is an example of a knee arthritis treatment. This was a 57-year-old man who had moderate to advanced arthritis in his knee. We ended up utilizing his own bone marrow-derived stem cells. And I'll show the areas that we ended up treating, but we ended up treating his medial joint, as well as his medial collateral ligament and the bone itself. His pain, and he's a few years out from treatment, has gone from 7 out of 10 to 2 out of 10, and he's really just doing great. The images on the left, the one on the top left, that's an arrow showing the needle injecting into the medial joint. This is the other pictures. This is that same needle essentially injecting into the bone. For more advanced arthritis conditions, we're now starting to utilize actually injecting into the bone as well. And the reason why is the bone itself is living tissue, and it feeds the cartilage with really very important blood flow and nutrients. And if the bone has been chronically damaged, what can happen, or if it's swollen, is that it's no longer feeding the cartilage with that kind of essential nutrients, which can then eventually lead to more damage in the cartilage. And so treating the joint will give pain relief. Treating the bone will actually give you better longer-term result, because it'll actually preserve the joint and the cartilage long-term as well. And that, by the way, is a relatively newer thing that's being done in regenerative medicine in the last couple of years. That's part of what this field is, meaning it is rapidly developing as we're learning new best practices. So common questions that I hear: can we treat bone-on-bone arthritis? This term bone-on-bone is a really terrible term, because it suggests that your joint is so squashed or destructed that the bones are on top of each other. From a practical standpoint, if you think about it, if the bones are right on top of each other and there's no longer a cartilage surface to kind of smoothly let the joint move, then your range of motion should be essentially nothing. And what we see actual range of motion is still intact and actually very good. And so that term bone on bone is not very helpful. It's actually a bit misleading. So yes, we can treat more advanced arthritis in the knee. And again, degree of improvement when it comes to knee pain, knee arthritis patients, is not based on how advanced or how limited the arthritis is. You can still get a great response even if you have more advanced arthritis in the knee, and that's very specific for the knee. So on average, the improvement for a knee case is about 70% improvement if we're using your own bone marrow-derived stem cells. Understand that arthritis is a biologic condition. We can treat not only the instability, the inflammation, and what's actually driving the problems that causes pain. If your range of motion and function is still relatively intact, good outcomes are still possible. We're talking mainly about knees today, but caveats to bone-on-bone arthritis, that term would be if you have advanced hip osteoarthritis, that's more challenging. That generally does better with replacement surgery. And always keep in mind that if you have more advanced arthritis, the expectations are more about pain relief and functional improvement, not as much about can we get your x-ray to look different or better. Image guidance is key to everything that we do. I have colleagues who feel that because of their experience, they don't actually need to use ultrasound or x-ray guidance. And the reason why is we're injecting structures that sometimes are so deep or so precisely located at a sub-millimeter level, you really should not be doing this blindly just by palpating the skin. So as an example, on the left side, that's an example of injecting into the medial joint and into the medial meniscus. The reason why you want to be precise is if you're only injecting a steroid, then there's just reduction in inflammation. And so whether you're in the joint or not doesn't really make a difference in terms of the outcome. On the other hand, if you're injecting your own cells, your own bone marrow stem cells, your own platelets, if you inject that into the wrong place, like if it hasn't actually gotten into the place that you want to deliver it, it's not going to be beneficial. So you have to be very precise. The picture on the bottom, again, is of an ACL treatment. You cannot do that blindly. You need high-level x-ray guidance to really hit that. That structure is too oblique and deep, and just you can't do that blindly. The picture on the top is of, again, that patellar tendinitis case. And ultrasound is necessary in that case because when you're going to be injecting the different levels of the tendon, you want to make sure you're thorough in your treatment, you're hitting everything. You can only do that under image guidance. And the last image on the right is an image of injecting into the bone. And again, if you're injecting into the bone, you need to be very precise from a safety standpoint because you don't want to be missing your target. You don't want to be hitting a nerve. And you want to make sure you're hitting exactly where that swelling in the bone is. So image guidance is absolutely essential for this. So to sum it up, how do you know if your physician is a regenerative medicine expert? A couple of things. Number one, they really should be focused on orthopedic and musculoskeletal issues only, joint issues, tendon issues. They shouldn't be focused on random other conditions. They should be focused on non-surgical treatments. They should offer you really mainly safe and effective treatments like these kind of treatments. They shouldn't be suggesting steroid injections first line. They shouldn't be focusing on chronic pain medications or burning nerve tissue. That's not what's best for you long term. They should be able to tell you whether you're a good, fair, or poor candidate based on the data that they've collected or the network that they're part of. They should be collecting and publishing data, which is definitely what we do in the Regenerative Network. Image guidance should be used for everything. They should understand that instability is a key part of treatment, that they shouldn't just be injecting into the joint. If you have knee arthritis, they should be injecting all those other structures as well. They should know the exact concentration of platelets and the stem cell counts that they're injecting. It shouldn't just be they're guessing what the product is. And then lastly, they should understand the difference between the different platelet products, bone marrow products, adipose, amniotic cells. They should have a really fine and high-level understanding of all that as well. So regenerative medicine treatments offer safe and effective solutions for your pain. So I see a few questions that are coming up. Okay, I'm going to answer a couple of these in the FAQ section, and then I'll answer a couple of the other more specific ones that are coming up as well. So a few things. Number one, is this too good to be true? So there's evidence, there's quite a bit of evidence on this. So to begin with, in the Regenerative Network, we have data that goes back to 2005. Philip Hernigue is a physician in France, orthopedic surgeon that has data going back for knees and shoulders to the mid-1990s. The experience, I have colleagues And colleagues that say, wow, this seems very new. But the reality is that there's data going back for these treatments that go back a couple decades. So while I have personal experience since 2008, there's experience amongst my colleagues that goes back even longer than that. So while these treatments are newer, they're not brand new. There's a lot of experience and data behind them. And in fact, when you look at the amount of published research that's being put out there for platelet-rich plasma and bone marrow-derived stem cells for orthopedic use, it is a profound amount in the last 10 years, actually. And so while these treatments are new and evolving, they're definitely not unknown. And if your physician doesn't have the experience behind it, they may feel like they're brand new, but that's not correct. There are definitely right and wrong ways to do this. And again, your expectation should be grounded in reality and evidence-based medicine. Treatment failures. So in cases where I've seen treatment failures, here's what I think you need to understand. Number one, complete treatment failures where people don't get really any relief is very rare. When those kind of things happen, there are a couple of things that I think of. Number one is there another underlying medical issue that might be driving problems? So for example, if somebody has an autoimmune condition, is that what's really driving things? And does that need to be evaluated and treated separately? If so, that could be preventing someone from getting the kind of result that they're looking for. In addition, there may be other sources of pain. So for example, if you have knee pain that's coming from a pinched nerve in the back, that could be causing your leg pain as opposed to just your knee arthritis, in which case you'd want to treat both the knee as well as the lower back. Also, your condition may require stronger treatment. For example, if you have moderate to more advanced arthritis, we're starting to realize that either you need to use a higher concentration of platelets, or you may be better off utilizing your own bone marrow stem cells if a condition requires more stronger treatment. I've also seen patients that have been treated without image guidance and they haven't had a good result. And that's because the physician's probably not really hitting the structure that needs to be treated. And then lastly, if their physician doesn't have a comprehensive understanding of how to do treatment, they may not be treating everything that needs to be treated. So for example, someone has knee osteoarthritis. If they're only treating the joint, but not also treating the ligaments, or in appropriate cases, if they're not also treating the bone, you're not going to get the right kind of outcome as well. So how long do results last? So what we see in the literature, and then I'll give you also my own personal recommendation. So what we see in the literature, Regenerative has data that goes up to 10 plus years now. Again, Philip Hernigue from France has data that goes over 20 years. And they have data that shows that there's long-term results. What I tell patients, however, is that if you have a chronic condition, meaning if you've had a condition that's been ongoing for 10 plus years, expect that you'll need a booster treatment at some point to keep your result going or to improve your result. The best way that we know to maintain results are, number one, after treatment, improve your biomechanics with physical therapy and exercises, take the appropriate supplements, and understand that repeat treatment is additive to an initial treatment. Meaning, as opposed to a steroid injection where you get a quick benefit and then back down to baseline, with regenerative treatments, you tend to get a slower improvement over time, and that result tends to hold longer term. And if you do have a dip, repeating treatment, you're now starting at that higher base, and you can get a stair-step effect where you're now building higher and higher after that initial treatment. Cost. So unfortunately, these treatments are not routinely covered by insurance. There are some exceptions, however, including if your company happens to be one that's open to adding the Regenerative procedures to their benefits plan. You can go to regenerativescorporate.com. They can walk you through that process. In addition, while Medicare doesn't cover these treatments, TRICARE, which is an insurance for active military vets or active military duty officers, does cover platelet-rich plasma for a couple things, including elbows and knees, but not everything else. So these treatments are slowly getting coverage, but it's going to still take time. If you ask around throughout the country, just kind of average cost that you can expect for something like platelet-rich plasma costs about $1,500, and stem cells are roughly $6,500 to start with. Keys to determine value, I would say, are number one, make sure your physician is an expert in what they're doing here, a regenerative medicine expert. Number two, are you receiving a real stem cell treatment, or are you getting a amniotic fluid treatment? There's a big difference there. Next, understand that these can be done in the office. They do not require being in a hospital or a surgery center, which typically drives up the cost as well. So, yeah, I see there are more questions coming. I think I've answered some of these, but I'll continue to get to that. I think the right way to approach your sort of chronic joint issues are, number one, your physician should be focused on non-surgical treatments for your conditions. Again, surgery is a whole different kind of a way of looking at things. They should be evaluating for inflammation, instability, asymmetry, neuromuscular issues. Try to correct with low-risk interventions, exercise, physical therapy, supplements, bracing as needed. If it's not working, then escalate to regenerative medicine treatments, utilizing the best options available, best quality products that are available, a plan that is specific for your condition, not one that is sort of generic for anyone that walks through the clinic, and then injecting with the highest level of image guidance possible. Okay, so I'll start going through some of the questions here. A couple of people asked about cost. Talked about that. Somebody's asking about what to expect after treatment, meaning how long will you be sore or painful before returning to activities. It's going to vary a little bit from person to person and based on the treatment that you do. So what I normally tell people is that after most regenerative medicine treatments, you'll have more inflammation for the first 3 to 7 days. During that time, you're not going to want to take any anti-inflammatory medications like ibuprofen, Advil, or Aleve. So you may need to take something like a narcotic for the first 2-3 days afterwards. For most people, that inflammation after 2 to 3 days starts to calm down. For some people, it can take up to a week, depends on the person. You'll then maybe have some stiffness for the first week or two after that, and then slow progressive improvement. In terms of return to daily activities, it's very much based on activities as tolerated. And by that, I mean, immediately after treatment, you're going to have some limitations, meaning you can do your basic daily care at home, but I'd avoid anything that's too strenuous. In terms of exercise, you'll probably be able to do some light, low impact exercises or activity, but I'd expect for that first week, you're going to avoid anything that's too impactful on that joint that's been treated. I personally find that if you work with physical therapy after treatment, that's a great way to escalate your activity tolerance, just with their ability to push you through and put more load on the joint that needs to be treated. All right, another great question. Somebody asked about, can you have PRP and a steroid injection around the same time? I would not recommend that. And the reason why is that the steroid injection, the way it works is that it'll actually block the effectiveness of what the platelets are trying to do. So you want to avoid that. Great question about, can you have treatments while on RA medications? I think if you're on the typical chronic RA meds, yes, that's okay to take. And the reason why is if you stop those meds, there's a good chance that you'll end up flaring up and making things worse. So in my experience, continuing those meds while you get treatment is okay. Some caveats to that, if you're taking chronic anti-inflammatory medications like ibuprofen, Advil, or Aleve, I generally recommend holding that for a week before and a week after. Number two, if you're taking chronic prednisone, you want to try to minimize that as much as possible. I do have some patients that have been on prednisone and been treated, and they've actually done okay, but I think at least from a theory standpoint, you want to try to minimize that as much as possible. In terms of a supplement standpoint, I have typically told people it's okay to continue your over-the-counter supplements, certainly omega-3 and glucosamine. I've had some experience recently where I think curcumin or turmeric can make you bleed a little bit more just because of how it works. And so I'm starting to recommend that people hold that around the time of their treatment as well. Great question. Some other questions. Someone had 2 PRP injections by their sports medicine physician. He wanted to know about repeating treatment. He said pain had returned after 2 years. What is the treatment for hands and feet? Okay, so yeah, I mean, I think if you've had a good response from treatment a couple of years ago, repeating treatment certainly makes sense. if assuming your condition is at the same level. If your condition has progressed, you may need to progress to something like bone marrow cells. Somebody asked about treatment for hands and feet. Again, I think it depends on the degree of issues, but consider utilizing platelets or bone marrow is certainly appropriate in the right cases. Okay, next question is, what is the knee arthritis treatment recovery period before I start exercising again, weightlifting and cycling? Great question. So a couple things. Number one is, I would expect for the first week after treatment, you'd want to hold off on that. I think as you start to get back into exercise, you'd want to go really low impact for the first 2 to 3 weeks that you start to reincorporate activity. Cycling, if you're going at a very low intensity, I think you're okay to do that even within the first 3 days, the first week. Weightlifting, if you're treating something like a knee, I try to minimize anything that's stressing the knee too heavily for that first 2 weeks up to even a month or so, depending on how you're responding. Okay, somebody else asking PRP injections about every 6 months. Normally work well for every 6 months. They want to know, can they actually then get a regenerative stem cell treatment? Absolutely. Platelets are additive to bone marrow stem cell treatment, so certainly makes sense and can actually be beneficial. Okay, somebody else asking, they're 67 in physical therapy for knee arthritis. Are they a candidate? Again, I think you should be evaluated properly. The majority of knee patients are candidates because knees tend to respond very well to treatment, better than really a lot of other areas. Knees tend to respond fairly linearly and consistently compared to most other conditions. So good chance that you are, but of course, you need to be properly evaluated to see if you're a proper candidate. Great. Another question, somebody asking very specifically about using TNF blockers, which is a treatment you can use for rheumatoid arthritis, psoriatic arthritis, and ankylosing spondylitis. Wanted to know, should they get off it? In your experience, have patients on TNF blockers such as Humira been able to get off it with the help of PRP injections? Okay, so if you mean replacing a medication you're using for your autoimmune condition with PRP, I think that's what you're asking. So I think it depends on your condition and what your issue is. So if you have, I think if you have a condition where you have 20 plus joints that are inflamed chronically, I think it's going to be hard for one of these treatments to replace the medication. On the other hand, I have a lot of great cases where, let's say an RA patient is on meds chronically, and that's controlling their overall inflammation, but they have 1 or 2 joints that are still problematic. In those cases, treating with PRP or bone marrow stem cells has worked very well. So I see it more as an additive situation normally, rather than sometimes replacing a treatment that you need for a bigger problem. So somebody's asking about pain when cells are extracted. So if you're getting platelet-rich plasma, that's just a blood draw. So it's just the same kind of discomfort you would have temporarily with a blood draw. For bone marrow aspirations, we numb it down a lot. You don't have to be knocked out for that. So the actual needle insertion is not uncomfortable with that. As the marrow is coming out, there's pressure and a suction sensation temporarily. There is some temporary discomfort with that. What's been described to me over multiple patients is that discomfort is relatively at 4 out of 10. So it shouldn't be more discomfort than that. All right, here's somebody else asking. Okay, great question. Somebody asking about, understands that regenerative treatments are not covered by insurance, but they want to know if ancillary treatments that are covered. So yes, insurance will still cover things like knee bracing, as well as physical therapy. They do cover evaluation, all that kind of stuff for sure. It's just the procedure part that is typically not covered. Okay, great. That was a lot of kind of rapid fire questions that came in all of a sudden. Right. So while I just kind of maybe wait a moment to see if there are any other questions that come in. If you're interested in being evaluated for treatment, You can either go to our website, chicagoarthritis.com, or email us at admin@chicagoarthritis.com. In addition, if you attended the webinar, we'll also reach out to you to see if you have any other questions, or if you'd like to be evaluated. For existing patients that are watching, of course, contact us anytime. And we're here to answer additional questions and help guide you through the process. Wonderful. Well, if there's no other questions, I'll give it like another minute. I will go ahead and log off and shut off the webinar. And I appreciate everyone's time. And as a reminder, we're here to help out in any way possible, whether that is through education, answering more questions, or whether that is just kind of talking you through what to expect from treatment with us. Okay, here's another great question. So someone else asking, does a bone marrow extraction affect bone density? Answer is no. So this has actually been studied about what is a safe amount of bone marrow there is to take out. So we take out a safe amount that's within that level. Bone density does not get affected by that at all. I think that term bone marrow extraction, it sounds scarier than it is, but it's dramatically less severe than what people expect for a couple of reasons. Number one is if you do this a lot, you tend to get good at it like anything else. Number two, this is a little bit different than how, let's say, a cancer patient may need a bone marrow aspiration. Cancer patient gets a bone marrow aspiration, they're frequently in a hospital setting. It's a more acute setting, much more nerve-wracking. Those folks tend to be much more sick. They have a lot less reserves in terms of being able to tolerate most medical procedures just because their cancer is kind of affecting them badly. And in addition, when you do a bone marrow aspiration for a cancer patient, they have to do a deeper biopsy. And that's something you don't have to do if you're getting it done for one of these kind of regenerative treatments. So it's not nearly as bad as what people expect. And not only is the pain not as bad as what people expect, but it doesn't cause any other long-term sequelae as well. Your bone marrow will actually regenerate that within a few weeks of being drawn out as well. So safe and low risk long-term as well. Okay, last call for questions. I know there's a couple of people on this who may throw in a last second question, so I'll pause for a moment. Okay, great. Well, thank you everyone for your time today. And again, if we can be of any additional assistance, please contact us on our contact that's listed on the screen. If you want to watch this later on, you'll have the option of actually watching this later as well. And until we connect again, have a good day and live well. Thank you. Bye-bye.